Good morning, everybody. It's war in Ukraine, but to keep your sanity and humanity here at home, we turn today to Dr. John Cohen. Dr. Cohen has, he obtained his undergraduate degree from Dartmouth College in New Hampshire, and then his medical degree from UNC Chapel Hill. He went to University of Wisconsin at Madison to do his residency in psychiatry, and then stayed on for a year as chief resident. And Dr. Cohen has graced the halls of this hospital since 1989. He's now an assistant professor of medicine, and in the past he was an assistant professor of family medicine. He is a past president of the Southeast Tennessee Psychiatrist Association, and he remains in private practice as well. He's an excellent speaker. I have had the privilege to hear several of his grand rounds. And if you look at the litany of talks he's presented, it would be 3 pages of his CV. But I welcome John to talk to us about keeping sanity and humanity during the pandemic and during the wars.
Well, thank you, Jigme. Yeah, I can't have any comment on what we do about the situation in Ukraine. That is well above my knowledge, pay grade, and everything else. But appreciate y'all being here. Initially, I thought I had no financial disclosures, but I started thinking about it a little bit. Both my boys are in the alcohol industry. I have a son who sells wine in France, and I have a son who works for Chattanooga Whiskey. And actually, I think the COVID pandemic has really been good for business for them, which is good news, bad news. Certainly for their livelihood, it's been a nice thing, but maybe not the best thing for all of us be turning to. At least that's why I have coffee outside and not wine or whiskey out there at this point. I did want to thank sort of inspiration, Dr. Panda, and also Jesse Kelly, who's new therapist over in the dean's office, who've been helpful just kind of talking about the whole concept of what have we been doing for the last couple of years with our lives and our livelihoods. So hopefully we'll learn a little bit more about how has the pandemic affected our own health, mental health, as well as lifespan, and how are we reacting as healthcare workers in this situation. And finally, how do we deal with this stress hopefully a little bit better than we might have been. There's no question, I think, as this has gone on and become an ultra marathon and not a sprint, that we have a very different adaptation mode than we might have thought back in March 14th of 2020. It's like, oh, okay, and this will be over by Easter, perhaps. So a little bit about statistics. It's interesting. Statistics in the US, to me, feel a little bit harder than statistics to come by in France. France has an amazing app on your phone called Tout Anti-COVID, or All Anti-COVID. And that's where we have our QR codes. You can find out vaccination rates. You can find out hospitalization rates, all sorts of things. But essentially, I did this a week or so ago. So at that point, about 930,000 COVID deaths had occurred since the pandemic started a couple of years ago. Clearly, the lifespan has declined. And that's what's remarkable is, in general, our lifespan in the US had been slowly inching up. And to see a reversal is pretty alarming. COVID is at this point the third leading cause of mortality, as opposed to in 2019, COVID was not on a list of anyone. No one had really heard of it, except for a couple virologists or immunologists in China. So actually, about a year ago, COVID was the top cause of mortality for 2 or 3 months, even sadly topping heart disease and cancer. A lot of maternal childbirth related morbidity and mortality, and some of that probably comes from women not wanting to go into obstetrics offices, not wanting to go into emergency rooms when they probably really needed care, fearing what's going to happen with COVID. And then certainly also women were discouraged, if not banned, from getting vaccines early on until we realized otherwise. In kids and teens, this used to be, oh, this is nothing. We don't worry about kids, pediatricians, I don't want to say didn't need to learn about it, but clearly that was false. And COVID has gone up to being at least the sixth leading cause of death as of the end of 2021. Huge controversy. Are COVID deaths overreported, underreported, or is this pretty accurate? And, a lot of naysayers will say, oh, hospitals get more money if they report that this is a COVID-related death than if it was a death from another cause. And then a lot of people aren't necessarily testing. Clearly in other countries, it's felt that, let's say in India, with a huge raging pandemic at times, many people were dying unexplained, not tested for COVID, but probably their rates of COVID death are much higher. Many people don't trust the Chinese government. I mean, they've had massive lockdowns, but are there very low numbers of COVID deaths accurate or perhaps also an undercount? So we'll go with what our CDC and others are officially reporting, but hard to know what exactly the best numbers are. Morbidity is another issue because just because one doesn't succumb and die from COVID, many people were having heart attacks at home. They were going into DKA at home and having diabetic crises, all sorts of other issues, cancers that could have been detected relatively early, treated, resected at stage 1, ended up people coming in with widely metastatic disease. And, so each field has reported that, we have issues where a delay in care has made a huge impact on people that are really suffering, if not dying from these other diseases because of the fear of going to emergency rooms or the fact that ERs were swamped and, they were not high priority on the list, and people also delaying primary care. As I talk about it, I'm on my last set of contact lenses, and I realize it's been 2.5 years since I last saw my ophthalmologist. I absolutely didn't want to go in there. He's a guy that gets about as close as I am to the microphone in your face, and I'm not convinced that he actually is wearing masks these days. So that delay in care is minor for me. I can still see pretty well. I might even be able to order some online lenses if I can get through Warby Parker correctly. But one way or another, that's a minor delay in care compared to these other things. We still don't know that much about this thing that we're calling residual symptoms, long COVID syndrome. At least 10% of those infected with COVID, but probably those who are hospitalized or in intensive care have much higher rates and more serious cases of long COVID syndrome. And that goes anything from the neurological to kind of brain fog and trouble focusing and concentrating to all sorts of other mysterious and troubling symptomatology. We also don't know a ton about will repeated vaccinations, will some of these new antivirals effectively treat it or not? Another area is post-traumatic stress disorder, and that is both in patients who've suffered from COVID, thinking that they were young and healthy and then ending up intubated for a week or two in the ICU is a really alarming, terrifying experience. And most of our experiences up until the last couple of years, we go through with loved ones. Family comes to visit, they hold our hands, we get all sorts of emotional support. And if the best that you can do is hold up your phone and hope for a FaceTime contact or maybe just a regular phone call, that's not nearly the same as going through an illness with a lot of love and support. So France looked retrospectively at what happened in the first 6 months of the pandemic, in the first 6 months of 2020. And they compared folks who were hospitalized in ICU for acute respiratory distress syndrome with COVID or with non-COVID causes. And the COVID families had about twice the rate of PTSD. About 1 out of 3 family members, not the patients themselves, but the brothers, the sisters, the parents, the children of those with COVID ended up with significant post-traumatic stress disorder when they looked at them about 3 months after discharge. So how does COVID impact your mental health, my mental health? I'm glad my kids are older and we're out of school by the time COVID rolled around because, for teenagers, this is really difficult. I mean, adolescence is not the easiest, funnest time in most people's lives. if you didn't have some challenges, some issues, you were either living under a rock, maybe you were homeschooled, maybe you weren't around other people, but kids have a lot more anxiety, a lot more depression. I think social media bears something to blame there, and there are some pretty good correlations between the more hours you spend on social media, probably the higher your level of anxiety and depression, even if you're an influencer with 28 million followers, whatever. Also, we see a higher rate of eating disorder patients who are seeking care in emergency departments. Clearly, if you look at standardized testing, kids aren't doing as well. It's my wife spent the first part of the pandemic doing Zoom classes, teaching 6th grade and 12th grade English. And it was not an easy thing to get kids on the screen, paying attention, really focusing. So it's another issue for those with kids trying to figure out. And, if you have very young kids, I mean, actually, some of them are remarkably good at technology by age 4 or 5. Nevertheless, the idea of a kindergartner learning to read on a Zoom doesn't work so easily, whether you're on the teacher end, the parent end, or the student side of it. It's a big challenge. There's also been significant increases in substance use or substance misuse and abuse. There's a really interesting thing I came across in some email feed that a study in Britain looked at, is red wine protective against COVID? And it's really hard to know about whenever you get a population study, a nutritional study, because if I ask, is coffee effective against COVID? How many of you are drinking coffee right now? And, it's, yeah. And is it a valid report? Is it a half a cup of coffee? Is it that whole, pot of coffee? How much do you need? Likewise with red wine. And self-reports are notoriously kind of inaccurate. The yes, no, I drink red wine, that part I might believe, but do you really limit it to one glass? Is it one bottle? How big is the bottle? But at any rate, this would be good news also for my son's business if we could show that red wine did in any way protect against COVID infection. We are not giving it in our ICU patients by any means, but it's more looking at those of us who are perhaps not yet infected or not reinfected. Wow, that would be really nice news if this were something medicinal I could do, but I wouldn't go out and buy red wine quite yet. And the last area we have to look at is deaths of despair. And, the opioid overdose numbers continue to rise. A few years ago, it was alarming that it was in the 50,000 or above range. And this past year, it looks like it's more than 100,000 deaths from opioid overdoses. And that is despite all of us cutting back on the rate and number of opioids that we prescribe. Also, it's estimated that rates of suicide have gone up. That's a little bit hard to come by because, those are conflated with, was this an opioid overdose that was accidental? Was it an intentional effort to end one's life? And there's a lot of disincentive to report suicide. If I want my loved ones to collect on my $1 million life insurance policy, if it goes down as a suicide, they might not be able to collect that money. So, our official stats of we have something like 35 to 40,000 suicides per year in the US, again, are probably an underestimate, but by how much, it's a little bit hard to know. Another aspect that I didn't include on this side is, I would say, an epidemic of loneliness. So my father-in-law is here towards the front. He is not so lonely because he's around us a lot. He volunteers here at Erlanger. But my mom lives in Durham, North Carolina, in a retirement community. And, she's got her own great apartment. They go down for meals. She goes to swim classes with other people. But for several months, they were pretty well locked down. You got a styrofoam tray in a bag, for a couple times a day. And really, we're not supposed to leave their apartments much at all and interact with other people. So, In her case, it's worked out all right to the extent that my brother and sister live nearby. They could kind of violate the rules. They could get her in and out a little bit or get themselves. But there are a lot of people who've really been locked down, shut in. So it looks like for geriatric depression, the rates have gone from, let's say, around 10% to around 20%. Again, you get different surveys, different estimates. And also, how does this affect cognition? So a lot of elderly are at least mildly cognitively impaired, and it may be worse into stages of dementia. And the more you're isolated, the more you're not talking to other people. If all you're doing is watching TV, that really does not help one's mental health or cognitive health. There's this DSM-5 is going to come out with a text revision in the next month or two, and a new disorder called prolonged grief disorder. And basically, it's viewed as a serious mental disorder, putting people at risk for intense distress, poor physical health, and potential for suicide, shortened life expectancy. So what is prolonged or grief disorder? Distressing symptoms continue for at least 12 months following the loss of a close attachment. And that is very much our U.S. Committee of Psychiatrists came up with this. Grief is very much cultural, individual, religiously determined in different ways. So 12 months is absolutely arbitrary. Could people be suffering from prolonged grief sooner than 12 months? Absolutely. Is it abnormal if you're still missing a loved one 15, 18, 24 months later? Not necessarily, but arbitrarily, it's 12 months after. And intense longing, yearning for the deceased person, preoccupation with thoughts and memories, and every DSM-5 diagnosis says it has to impair to a clinically significant degree your function, whether as a worker, a family member, a student, a parent, a partner, and it's really impairing your function every day in the last month or more. And you feel like a part of yourself has died. The emotional pain does not go away. And the feeling that life is meaningless because of the person I've lost. How much of the population does this describe? Anywhere from 7 to 10% potentially. And in this time of COVID, that number certainly may be that high or higher. If we look at other situations, I look at what's happened to Syria in the last decade, I would imagine that their degrees of PTSD, grief are remarkably high. If we think about what could be happening in Ukraine in weeks and months ahead, potential for a lot of that. But then also, there's a whole issue with, we've had all these COVID deaths that aren't necessarily recognized, acknowledged, celebrated in some ways. If you have a memorial for someone's life, a funeral, or mourned in the same ways because of COVID. So if you were to seek therapy for prolonged grief disorder, it is not a pill that I can prescribe. No SSRI, no other simple pill. Sure, we can give sleeping pills, we can give benzodiazepines, but it's not going to fix it. So how do you help someone understand and accept the grief, managing their own emotions? Ultimately, can you see that there is a future without this loved one, without this colleague who has died? And for those of us who are left behind, how do we strengthen the relationships that are still there? If you've lost a parent, can you cleave to that other parent or to your siblings or to your children? But how do you make sure that there is still some connection? And this idea of narrating the story of death has been taken away in many respects. So often we've had the notion of, here's what happened to my loved one. And a lot of people have no clue. I mean, I had to drop him off at the ER. I couldn't go inside. And then I got a call that he was in the ICU and they were putting him on a ventilator. And then 4 days later, they said he's not doing well. And I may or may not have even had a phone call, FaceTime, and then this person has died. So it's not nearly the same as, dying at home, which was tradition until about a century or so ago, or at least dying in a hospital setting where loved ones can visit and be part of that whole process. And then how do you live with reminders of that person? I've got one woman who sadly lost her husband to COVID probably about 1.5 years ago now. And she's a wreck. It's understandable, but everything in her house is a reminder. I mean, she has not been able to get rid of anything that he owned. And we've talked a lot about how his old boxer shorts, his old gym socks aren't really going to be of any use to her whatsoever. You know, could she choose, let's say, one sports jacket that he wore and she really loved, or a lot of trophies, other mementos? But how do you get rid of these other things? And actually, how do you help out other people in the process? Many people might be willing to wear his old gym socks, just not her. And so how do you help people through that process and, you know, connect with memories in a good way and not just totally, how do we honor that life that was lived and not just totally have to block everything out? Some of that blocking out has been necessary for us as clinicians because we're dealing with so much. Read an interesting article about how an ICU nurse deals with deaths and losses. And what she does is after that person has died, she'll count to 10. She might need to count to 20 or 30 and let the emotion roll over her and feel whatever she wants to feel, think whatever she wants to think about that person. But she also recognizes, I can't count to 1,000 because like there's a lot of other people who need my help here, but I do need to take at least some moments before I try to move on to the next person. There's this psychologist I hadn't heard about until the last year named Pauline Boss. She's about 87, 88 at the University of Minnesota. And she grew up really close to where I did my residency in Madison, Wisconsin. And she's come up with this concept of ambiguous loss. So we always talk about, you know, with grief, with loss, we want to get closure. And closure, I think, is probably elusive and maybe not so realistic anyways. But the idea is that a lot of people are lost, but in an ambiguous or unclear way. So one would be people with severe levels of dementia. I missed part of this line. They're physically present, they're still alive, but emotionally, cognitively, they're gone. So, you know, your grandmother may not recognize you at all, or certainly may not have the same sort of attitudes and behaviors that she did. People are substance abusers that may literally be living homeless on the street, or may be so out of it, so wasted that they're not really there as a brother, a sister, as a parent. And then also people who have died in wars. You know, we have this Tomb of the Unknown Soldier and other monuments in our country that, you know, there's not been a body found. We can't exactly have a cremation, a funeral without something. Clearly this happened a lot after 9/11 when the Twin Towers fell. So there are various situations. And then, as I said earlier, COVID deaths that occur, but we don't have a final visit, a memorial. So we've kind of gone as healthcare workers. It's been interesting. I think, you know, 10 or 20 years ago, not that many people really, I didn't feel like noticed doctors, nurses, respiratory therapists, all those folks in quite the same way. But the last couple of years, we've been front and center. And, you know, in New York City, people were banging pots and pans as the healthcare workers were changing shifts at 7 a.m., 7 p.m., you know, to honor them, to celebrate them, to appreciate them for really being. And Erlanger gave out these healthcare heroes. A hero works here. I don't see any sign right here, but they're all around, you know, or used to be. These little t-shirts or long sleeve shirts that we were all heroes for working here. People dropped everything, flew to New York City or whatever the next epicenter of the pandemic was to, you know, staff the COVID units. And back then, Dr. Fauci, I mean, I thought Dr. Fauci was amazing back when I was in medical school. He was the face of the HIV/AIDS epidemic and kind of studying and understand this. And I mean, Dr. Fauci was a hero. He hosted Saturday Night Live. I mean, that's pretty amazing, for a PhD, epidemiologist, immunologist, who's a physician to get to do that. Never happened before. And now he's viewed as someone who receives death threats, who has to testify before Congress and in front of senators who are also doctors and defend his thoughts about the pandemic. So he's seen quite a big swing as well. And now we look at traveling nurses. We've had one of my favorite nurses here told me that she wasn't going to be on West Wing 3 and 3000 anymore because she could make at least 3 times as much as the traveling nurse. She's got kids who are in high school and needs to worry about their college. I mean, it's hard to blame her, but article I was reading said some traveling nurses, and then maybe we want to not be physicians, but be traveling ICU nurses, were getting $10,000 a week in New York City. I know you've got New York state taxes, but still, that's very, very high level of pay for combat pay. And now doctors, nurses are viewed by some patients, by some families, as liars. I can't tell you how many people in the ICU have been confronted by the patients themselves who are angry, or their family members who say, this can't be COVID. This isn't real. It doesn't exist. And it's really viewed as just a total hoax. So another troubling thing, this is one of our state representatives, John Reagan, a Republican from Oak Ridge. And this was published about a week ago in JAMA. Under pressure from Reagan, the state medical board has removed the medical board statement warning that physicians who spread disinformation about COVID-19 could put their license at risk. So this is basically saying we must not sanction physicians even for spreading misinformation. Florida, where Ron DeSantis is governor, legislators have taken away the medical board authority to discipline physicians for the same reasons. So very troubling. We, on the one hand, believe we have, the right of free speech. Also, we're obligated to spread good scientific information, but this is effectively a gag order. Before I get to this, slide, recognize the symptoms of stress you may be experiencing. One that didn't get included is, how do we talk to those angry families, to the COVID deniers? And had dinner with Adam Soufleris, one of our infectious disease faculty, and he's had a couple really good lines that I liked, which I thought are hard to necessarily tell people, but they don't want to listen. But one thing he says is, I'm really sorry that you chose to listen to unscientific sources of information about COVID. And another is, I am sorry that you decided not to get vaccinated because of people spreading fear and lies about the pandemic. So I'm sorry, but this is the choice. And at the same time, we'll do everything in our power to relieve your suffering. And also, I hope when you get out of this hospitalization, this intensive care unit, that you'll share with your loved ones how important it is for them to get vaccinated or boosted to avoid your situation, assuming that you're going to make it out alive. So not easy to calm yourself down and say these words, but I thought wise ones and not necessarily reacting with anger, because it's one of the many emotions that we do feel. It's hard not to get really, really upset with people that are just throwing this in our face when you're doing your level best for 80 plus hours a week. None of our residents are working the plus hours, 80 or fewer hours a week. Others may be working more, but there's also a lot of uncertainty, nervousness, anxiety, maybe a little less so now. I mean, in the beginning of the pandemic, I didn't know if the groceries that I was bringing home needed to be wiped down because they might be spreading COVID. People were taking all sorts of extra precautions that we now realize aren't quite as necessary. But that whole feeling of being pretty helpless or powerless to change things. It's easy to lose motivation when it's the same thing day after day after day. Obviously, the fatigue builds up. And, it's okay to acknowledge that I'm really sad, I'm really upset about this, maybe about this person I got close to for a week in the ICU, or maybe about the fact that I can't, travel to visit my family. I can't go across the globe to visit friends or family there. Trouble sleeping is extremely common. And some of that is long work hours. Some of that is changing shift hours that we're asked to do. And when you have trouble concentrating, it's like, how do you balance? Should I be here? Should I not be here? What am I doing? Am I helping patients the way I need to? So working on enhancing our own resilience, I think talking about this is really important, whether with our coworkers, our supervisors, people that are employed at our institution, just about what I'm going through, and to basically be able to say, this sucks. I don't like it. I'm not happy about it, but how can I continue to go on even in the face of a lot of challenges, a lot of difficulties? And what is it that causes stress? And what causes me stress, maybe not the same thing that causes someone else stress. And how do we work together to find solutions? If I don't eat, I don't do well. So I've definitely had a good breakfast already. I'm not caffeine dependent, so I didn't have to have coffee or tea before this. But for other people, it's just the opposite. I've got friends, patients who never eat breakfast, but if they had to start their day without coffee, they're useless. So that's one minor factor. But how do we take care of ourselves? And our resources are limited. Fortunately, they're not as limited. I don't know that we've ever gotten to the point here where we're, nobody has a mask to wear, or nobody has, a shield or a gown to wear. We've been relatively fortunate in that area. We've had a lot of deaths, but we haven't had refrigerator trucks parked out front of Erlanger, stacking up bodies. So as bad as it's been here, it's been far, far worse in other parts of the country and other parts of the world. And acknowledging that I don't like this, I don't feel okay, and is it okay not to feel, like the standard answer, or when people say, what's up? Oh, fine, I'm good. Like, not really. It's so easy to say, and I have countless patients who walk into my office or pop up on a video screen now, and they'll say they're fine, but really, if you get beneath it, most of them aren't that fine. So acknowledge that this is really difficult. I don't feel good all the time, but can I have moments or when I start to feel better? And, also looking at, we're doing the best with limited resources. We have lots of empty beds in the hospital. We just don't have nurses and other people to staff those beds. So how do we deal with what we are left with? And in terms of enhancing resilience, this is a huge challenge. Ideally, I do well with a consistent schedule. So I do not ever choose to work night shifts, or, there are all these telepsychiatry overnight jobs. And that would be probably one of the last things I'd want to do. I think I'd rather go be a barista at Starbucks during the day than practice my field at nighttime. But, as much as you can keep on some sort of consistent schedule, and that doesn't just include what time I go to bed, what time I wake up, but it's, do I eat breakfast? What time do I eat breakfast? What things am I driving through Dunkin' Donuts and picking up a dozen donuts and eating half of them on the way? Or am I actually having something more nutritious than that? Trying to get adequate sleep sounds really good. I've got a slide later, and the numbers don't always work, and time to eat healthy meals. So I will tell people it's important to do that. My time to eat meals sometimes is standing up, because a hazard of being a psychiatrist is you sit a lot and listen to people. And I'm also sitting and typing on a screen. So standing and eating sounds antisocial or like a weird thing to do, but for my body, it might actually work a little bit better sometimes. Family dinners, we don't stand and eat. We do sit. So I don't want to give you the idea that nothing happens normally. And then can you also take breaks to rest, stretch, check in with people, a buddy check, anything like that. And a break does not have to be 30 minutes where you're off the clock. It might be, can I go somewhere and whether, do some, calisthenics, a yoga pose or two, something for a minute. Can I get away and do some, relaxed, deep breathing? Don't do this while you're driving, but any other time of the day, that can be really useful. And exercise, I mean, that is like my number 1 and 2 and 3 stress reliever probably. So I've already gotten up and done a short run this morning. I think I know there are people who like to run on treadmills. Dr. Davis is a good example of that. I could probably run five times as far outside as I can on a treadmill. It bores me, and I'm not a big fan. But for other people, it works, and it's where they can go. But if you can be outside, I think that makes a huge difference. Nature is actually pretty wonderful. So, the fact that like we have daffodils popping up in our front yard, or there are cherry trees starting to blossom that smell really good in our neighborhood, just little bits of appreciating that. And especially early on, people were glued to TVs wanting to hear all the latest updates. And that does not serve any of us very well. I mean, you can catch 5 or 10 minutes of headlines in the morning and the evening and know what's happening. For anyone who's concerned about Ukraine, I mean, there'll be breaking news for the next 24, 48 hours, and stations will be reporting live. I can't watch that all the time. Partly I've got a job to do, partly I've got to sleep, but it's also at some level pretty upsetting. And, if there are things that we can change, absolutely, we want to know about them, but turning it off. And then also social media. Again, the teens the more time they spend on social media, the worse their levels of anxiety and depression is a concern. So when we're extremely stressed, you go to basic survival mode. I want what I want right now. I've got to have it right away. I don't really care what you want, what you think, and we're not always very rational. So that's why sometimes people will, when confronted, pop off against someone else. My wife went to University of Michigan, where their basketball coach was filmed punching an opposing basketball coach. So his brain, Juwan Howard's, was under extreme stress. He now regrets it, but how do we not kind of fall into that same trap? So staying centered and calm is a huge challenge. When I put up this slide, I said, well, set a regular bedtime and get up 8 or 9 hours later. Then I started doing the math. So you guys, there's 168 hours in a week. That's always been the case. And if you have an 80-hour work week limitation, that leaves 88 more hours. I'm not even going to talk about getting to and from work, but if I'm asking you to be in bed for about 60 of those hours a week, that only leaves 28 hours when you're not at work and you're not in bed asleep. So forget that math problem. 8 or 9 hours in a resident schedule may not be absolutely realistic, but it's a laudable goal, and probably we function better if we're at least relaxing, if not asleep much of that time. I honestly don't get 8 or 9 hours of sleep a night either, and I have a much better schedule than you. And just along those lines of scheduling, I hate to say that you are protected here with an 80-hour work week, but the reality is once you go out in the real world of practice, whether you're in academics, private practice, if you want to work more than 80 hours a week and work 100 hours a week to pay off your loans or to buy a new Tesla, you can do it. And maybe your partner will stop you. Maybe he or she will walk out of your life. But the reality is, we have this artificial kind of limitation on the work week. And the other way I look at the work week is, my kids are all working full-time jobs, and they work about a 40-hour week. I think in France, they work 37.5 hours because of their system. So you guys are working 2 jobs, not 1 job when you're working an 80-hour work week. And, so I think the idea of getting out in the world and maybe even working more is pretty appalling. And then the challenge is, do I need to even work this much? We don't give residents as many choices, but once you're out on your own, think about tapering down rather than ramping up the hours. So how can you at least do something? Can you walk? Can you do light weightlifting? Can you stretch? So the stairs here are a really good resource. Some of them have cockroaches that are dying. Some of them, they don't have as many cigarette butts as they used to, but still, if you can stand the grossness of the stairways, it's really good to go up or down a few flights of steps rather than waiting for the elevator. And then if you can get outside on days, spring isn't quite here. Today it feels like it is, or get out in the evening. We're going to go to daylight savings time soon, when it'll be actually light until probably 8:30. So even those who work later hours, hopefully, can see a little daylight. Light is therapeutic. We have this thing called seasonal affective disorder, which is when you don't have enough light exposure. And these fluorescents don't do it. It's sunlight, it's high intensity, bright lights that really help. And so I think the more you can be outdoors, that can help. There's the TIPP skill to de-escalate, and temperature is one part of that, intense exercise, paced breathing, and progressive muscle relaxation. So briefly on temperature, the idea is we want to activate our parasympathetic nervous system, and what does that is cold temperature. So end of the day yesterday, I went to the Y and swam, and pool was comfortable, but I took a normal hot shower, but then I turned it to cold. And the cold shower is actually very helpful to activate the parasympathetic system. Another that you can do is, sounds kind of weird, but plunging your face in ice water. So that ice bucket challenge for the ALS, that's a full body sort of thing, but you can just do your face and your clothes don't get soaking wet. Or even short of that, you can drink something very cold. You can put ice cubes on your tongue. So anything like that. Humming will perhaps activate the Valsalva maneuver. You might drive your family and friends crazy if you're humming all the time, but you could try that. And then intense exercise. You may not have time to go for an hour walk, but could you do sprints up the step, or do 1 minute of intense fast walking, and that may be at least something. The more intense, or pick your weight exercise or push-ups or kettlebells or whatever. And paced breathing is just kind of, think about a yoga class, a relaxed, slow in out breathing, and then muscle relaxation, tense and relax. So, and the other skill is the stop skill. How do I tolerate these difficult moments? So when I feel like I want to snap back at you or tell you what an idiot you are or berate the family member, stop. Do you have to say anything? Take a breath, step back. You may not have a 5-minute break, but even a 30-second break, maybe just a long enough fuse, so I'm really not going to pop off and say or do something that I regret. And then observe the situation. I mean, there are two sides to every argument, every situation, and usually that other person isn't really trying to severely attack you as much as they're in their own stressful situation. So we have that all the time in handoffs, or who's going to deal with what aspect of what patient care. And let's step back for a minute, and maybe I've got a misread on the facts. And then proceeding mindfully, what do I really need to do right now? And most of the time, I'm not sure I need to do anything. Can I just step back, observe, and I don't have to necessarily react, say, do something. I'm not talking about a code situation. There you need to do things, but in these interpersonal relationships, don't always have to react. So if you takeaway points, if we want to be better healthcare workers, healthcare providers, how do you take care of your own mental health, your own physical health, your own brain health? And rest is vitally important. And people get rest in different ways. I never take a nap. My mom, my dad loved to take naps, but that's just not the notion of a 20-minute power nap. Doesn't work for me, but for some people it does. But other ways that you can get rest, or even just when you have a break, don't immediately, get on Facebook or start, looking at Instagram. But can you just let your mind put this thing away? Don't be on electronics. And any kind of physical activity that you can do is likely to help your mental health as well as physical health. So concluding, if we take care of ourselves, we'll do much better to take care of those patients, our friends, our family members who need us. And that's really the challenge. How do we keep there for each other? Because like I said, this has become a marathon, an ultra marathon. And even though we think as Omicron is waning, we're in a better situation. But I think my worry is we're all going to learn the Greek alphabet better than we ever cared to, and know about all these other letters that come after Omicron. So it's not clear that we're going to necessarily be 100% clear sailing as much as, okay, now we've got a calm before the next storm. Also, being grateful, expressing gratitude, for people around us, for people who are helping us, people who care about us. That makes a big difference. I've got a good friend who doesn't like to cook because her husband could care less. He doesn't know how to cook. He can't make a piece of toast. But, she doesn't like to cook for him because he doesn't care. He's not grateful. But the more we can express gratitude, for little things that people have done for us, with us. And we are a team, however you define this team, the entire Erlanger system or a lot of subunits of that. And how do you take care of each other? How do you make sure that everyone is hopefully on the same page and checking in and letting people know they've made a difference? So thank you for your attention. And let me see if there's any questions. Yeah, James.
Dr. Cohen, thank you very much. I would recommend that you challenge your sons to do a head-to-head of wine versus whiskey on COVID, and I'll make it on whiskey.
Okay, thank you. So for those of you on Zoom, Dr. Haynes, our interim dean, said, challenge my sons to do a head-to-head on wine versus whiskey during the COVID pandemic. He bets that whiskey, which is certainly a lot more potent, would be the victor over wine. But each person has their own preferences. Yeah. Yeah. Mike. Yeah.
I can't follow up with Dr. Haynes' question, but as someone who worked on the vaccine development process, the intensity of what went into vaccine development and the hope came with it, and the disappointment in it not being accepted, and then the surge came in August, just tore down my house simply. I guess looking back at that and looking forward to hopefully maybe not another surge, but how do you handle the expectations or I'm not sure how to put my question together, but essentially I feel like I need to be better prepared for another surge of unvaccinated bad outcomes. And so how do I get ready for that? They're blindsided me in August.
Yeah. So for those of you on Zoom, Dr. Davis's question summarizing was, it was devastating to him to see how many people refused the vaccine. And therefore we had this immense surge back in August, which was the Delta surge, followed by an Omicron surge, several months later. And how do I prepare myself? How do we prepare ourselves for the fact that so many people are declining, outright refusing, the vaccination, and how do we prepare for what might lie ahead? Because there may well be another surge. And it's not an easy sort of thing. It's like, okay, I've just gotten to the end of this marathon. And if you're a marathon runner, you're not supposed to do a marathon more than once every few months. I know there are crazy people that do a marathon on every continent in a week, but barring that extreme, how do we get ready for what might lie ahead? One glimmer of hope is I've increasingly heard from patients about themselves or family members who a year ago were staunchly refusing the vaccine, even 6 months ago, and that, oh yeah, my daughter finally did get vaccinated, or the fact that my son's a nurse at a hospital in North Georgia, and he was going to lose his job if he doesn't get vaccinated. That will incrementally bring the numbers up, but it still isn't going to be like European countries where 90% of France was vaccinated, at least at an adult level. So preparing ourselves is sort of like, okay, I might be going into this again. How can I, maybe if we do have such a thing as a lull or hiatus, can I enjoy that now? Can I get to the point? I mean, we started traveling again and went to visit Morocco. I missed the picture I was going to put up, myself riding a camel in Morocco, which is pretty amazing to get to do. And so can you do things like that? Or yeah, it's almost like, what do I have in the bank? Do I have a reserve that I can build up now? And that's not always easy to do, but developing as good habits as we can, whether that's nutrition, whether that's self-care with exercise, whether that's sort of a mindfulness practice, and also having colleagues that you really feel like you can know and trust and relate to helps. But yeah, it's not easy because there will be those people who get sick again, and even though our numbers are better, 100,000 new cases a day of what gets reported is not good. It's just not as devastating as it was, a few months ago. Dr. Panda? Yeah.
Thank you, John, for very practical and important talk. So what you spoke about and its impact is not new. It has just been amplified and elevated in the past 2.5 years.
Mm-hmm.
And I just wanted to hear your thoughts on how do we infiltrate this into the culture of a system?
Yeah.
I mean, why is it that we keep speaking about it, but yet it is not apparent? We're hearing about the Great Resignation, right? We've gone from the RVUs to now the EVU, which is the educational value.
Yeah.
But how do we bring that emotional value unit back into who we are, into the system?
Yeah. So Dr. Panda's question is, the pandemic has brought this forward again, but we've been dealing with this whole question of, how do we deal with our system? How do we have something called an emotional value unit? And how do we take care of each other? I mean, a few years ago, we had a speaker from Mayo Clinic, Tate Shanafelt, come and talking all about, taking care of ourselves as physicians, whole issues with burnout. I mean, this is not new. The pandemic has, brought it up again. And it is a challenge to always keep that front and center because we have people resigning from our field as healthcare workers. We have teachers who are resigning early and, just saying, I don't want to deal with this situation. And, my hope is some of those people may find their way back to the workforce in general. Maybe we'll have teachers retraining as nurses and nurses retraining as teachers, thinking the grass is greener on whatever other side. But it is very difficult to say, how do we pay attention to what matters? And that's sort of the culture of a place, and if it's as small as your individual private practice, how do we take care of each other in that way? How do we take care of each other, at a larger system in a residency program and a hospital setting? I was kind of sad to see that I think the College of Medicine was going to have some sort of big gathering it was after Christmas, but they were, have everyone get together and they said, it doesn't feel safe to do this right now, but please let us know what size t-shirt you would like. And that sounds really nice to get a long sleeve t-shirt that says something, but it's not the same as gathering and having, communal food and drink and seeing each other. So I think, how do we keep our eye on the fact that, people are why we went into this business. I mean, nobody is a healthcare worker, even those specialties that don't talk to people. They all went in to relieve suffering, to care about improving the welfare of other folks. And how do we look at doing that for ourselves before we can do it for other people? Yeah. Natasha? You're welcome. Yeah. Dr. Haynes, yeah.
Walking around the hospital sidewalk, quite frequently at all hours of the day, too much at night, certainly during the day. And my colleagues and I, we try a bunch to make a walk around those athletic fields as well. In the meantime, those are just take advantage of the daytime and get up and get out. It takes us about 20 minutes and we're done and back at it.
Yeah, so Dr. Haynes' comment was, can we go for walks? And you can even do walking rounds. It's really hard to look up a patient's information, although my residents are far more adept at pulling up things off their phone from Epic and Haiku than I am. But, if you can even be outside for a short amount of time, it doesn't take, an hour of dedicated exercise time. That would be great. If you can go to Orange Theory and do your class for a whole hour, wonderful. But, minutes or half hour here and there really add up and make a difference for us. So, Dr. Sid,
Dr.
yeah,
Cohen,
yeah.
I think this will be the last question. In casual conversation, I often say, hey, half jokingly, the two things that have changed for me in the pandemic is I realize now you should wear a mask and walk into a bank and not get a belly full of lead. But the second thing is we've got patients who at the very end of life, cognitively intact, can't breathe, have to say goodbye on Zoom. I cannot imagine such a circumstance, and I've lived it every day. And many of us healthcare workers feel we were less than compassionate. And when families were allowed finally, it was for 20 minutes. I wonder on the opposite side in your practice, are you seeing patients, not patients, but loved ones who lost family members in this manner have anger about the process of not being able to say goodbye? And does that anger predispose to this ambiguous loss and the prolonged grief syndrome? I wonder how big of an issue it is because I don't get to interact with them after the fact.
Yeah, so the question is, as an ICU doctor, seeing patients die and not having contact with their loved ones or only having a minimal interaction on Zoom, how does it affect those family members weeks, months, now a year or more down the road? And it is really, I think that's an evolving situation because, for so many people that have had death of a loved one in hospital from COVID without really getting to see them, to say goodbye, sometimes not even realizing how sick they were before things just catapulted to the end. It is really this sense of, lack of closure, ambiguous loss, and they're angry probably in so many different ways. I mean, there are people who are angry because I got vaccinated and my loved one refused to. There are people who are on the opposite side, they're angry because they feel like, we as a healthcare system haven't been able to save everyone. That we now have these medications that are out there. They're angry that they're not getting ivermectin or they're not getting hydroxychloroquine, and that we're not willing to give a unscientifically proven treatment. So the anger, the hostility, I think it boils up in lots of ways. And ultimately, that makes it really hard to get to a point of forgiveness, acceptance, which I think is important to, for any of us trying to deal with the loss. They may not ultimately say, I forgive you, you did everything you could in your intensive care unit, and they were beyond saving. But that would be for that individual. You may never hear it as the doctor, but it'd be great if the family members could come to that sense of acceptance and forgiveness. It's a hard place to get to, though. So, well, thank you for your attention and time. Yeah.